Okay, so I appreciate that I've had a lot to say about that, and I've maybe not written all of it down. And most of it's just kind of flown out of me when I'm talking, and it can be quite garbled. So I just want to overview some of the things that you can correct with ATE and where you would correct them. Because this is, again, just an introduction to critical care and the things that we can do. And I wouldn't pretend to understand the intricacies of some of these things. So in an airway situation, mechanical intubation, ventilation, tracheostomy or surgical tracheotomy, those are the critical care interventions that can get done almost selectively in a level 3 or an intensive care situation. Within the breathing section, ECMO, we didn't talk about that. And the reason we didn't talk about it is because it's very, very complicated. And it's generally with the scope of even most critical care units. And it's generally reserved for tertiary cardiac centres. There's actually a really good picture of a patient lying on the Louvre in Paris on the floor. And there's a French critical care retrieval team who've just put her on ECMO. And what it is it's extracorporeal membrane oxygenation. And the way I think about ECMO is it's like dialysis for your heart and lungs. It's essentially the same as what happens when someone's getting a heart transplant or a heart operation and they get put on the cardiopulmonary bypass machine and they let a machine do all of the oxygen transfer for their heart and lungs, and it pumps everything around the body for them, acts as a mechanical pump and does gas exchange. Very complicated, very dangerous, very specialist, and it's only done in extreme situations. But it's a life-saving therapy, and in the next 15 to 20 years, I have no doubt it'll be everywhere. There's some seriously good trial evidence to suggest that ECMO can revive people with good function even 24 hours after death in hypothermia. People who've fallen into a gutter at the side of the road. There's a famous case where a man fell into a ditch, fell asleep, died of hypothermia. They found him in, I think, the morning or the day after, and they put him on ECMO, resuscitated him, and he was alive with a decent function at the end of it, which is pretty extraordinary. IPPV, that is, again, that's just mechanical intubation and ventilation. It's invasive positive pressure ventilation. NIV, which is BiPAP and CPAP, remembering that's the tight-fitting masks that we put on people, which can apply some pressure when that's what's needed to assist their ventilation. And then oxygen delivery devices, all they do is increase your fraction of inspired oxygen. So that's when there's less of a mechanical failure in your breathing and more of one of a failure of gas exchange from any number of issues that we talked about before. Within C, we didn't talk about aortic balloon pumps. And again, that's because they're well within tertiary cardiac centers. So the reason that you might use this is if your heart was well and truly gubbed. And what I mean by that is your heart's not pumping due to maybe a massive heart attack or cardiomyopathy, for example, or myocarditis, and your muscles of your heart are just not working and your heart's gone floppy and it's not pumping correctly. It's not giving enough pressure to pump the blood through the body. What this does is it blows a little balloon up in the center of your aorta to increase the pressure to allow your heart to pump harder, and it selectively inflates and deflates with the cardiac cycle, increasing pressure significantly. It'd be worth watching a few videos if you're interested in it. Inotropes and vasopressors, we talked about them just very recently. Fluid resuscitation, internal and external pacing. So you can either have a line run through your femoral vein into your side of your heart with a little pacer that sticks in the right ventricle and gives an impulse to keep the heart beating. Or you can have little tabs placed on the chest which send electric shocks through the chest wall to facilitate a heartbeat in people that have a bradyarrhythmia or a heart block, and blood transfusion, which is similar to fluid resuscitation. We didn't talk much about D&E. So within D, correction of glucose, although that's maybe not necessarily an organ support, that's probably something you should never forget about. So I've thrown it in there. Neuroprotective ventilation. So people with head injuries or people with bleeds in their brain, what neuroprotective ventilation is all about is reducing the carbon dioxide within the body, and that's by ensuring that your tidal volumes and the pressure in which you're breathing is adequate to blow off all of your waste gas. The reason for that, and the reason for aiming for you to have a very low CO2, is because for people that have some sort of space occupying lesion or mass in their brain or a bleed in their brain, they might not have enough, there might be a lack of space there, and there might be pressure effects. Having a lower CO2 reduces vasodilation of vessels, and it allows more space to appear, less blood flowing into the brain. If there's, for example, a bleed and you want less blood flow, for example. Anesthetic and benzodiazepine infusions. I include this because if someone, for example, has a status epilepticus, is having lots and lots of seizures, sometimes the final resort for protecting their brain is to anesthetize them or put them on an infusion of benzodiazepines. Also, people that are just purely bonkers, really delirious or psychotic, this might be the only way to manage them, is to essentially put them in a coma, and that's preserving their brain tissue and potentially preserving their life. And then again, in the E section, renal replacement therapy. I didn't talk much about that because, again, this can be provided in any intensive care unit as renal replacement therapy. They have hemofiltration, which is a form of hemodialysis, and allows you to excrete waste products and also do the normal function of the kidneys. So what I mean by that is, if you had a toxin in your body and that's why that you've entered intensive care, then that is also an option. People that are very hypothermic can have warmed fluids put into them, and they can also have bear huggers, which are essentially just inflatable blankets, which have hot air blown into them through kind of a wee machine that blows hot air. So there's lots of different things that you can do to correct the abnormal physiology. And what I would say is, overall, that is the aim of intensive and critical care. Is all you're really doing with the patient is you're not doing anything miraculous. You're not giving a specific drug to do a specific thing. The vast majority of intensive care is correcting the patient's physiology so they stay alive long enough to fix themselves. And the important thing is to recognize when somebody's heading in this wrong direction. And in order to recognize that, you need to kind of know a wee bit about normal physiology so that you can then pick out the abnormal